So good afternoon. We will start the next session, Reaching the Unreached, Human Touch versus Technology. So we will be talking about what is medical cam, ICAM, what was the past, what was the present condition, and what is the future with the AI technology. So we have 5 speakers. So first speaker will be Dr. Babu Krishnamar. He will give the introduction. Then second talk is by me, what is the ICAMs in the past. And Dr. Dada Ramanan, what is the corporate and outreach camp activities. And fourth, Dr. Rohan, what is the camp activities in the government setup. And finally, Dr. Tanishri, she will enlighten what is the future ICAM using AI technology. And there will be a final discussion. Over to Dr. Babu Krishnamar for the introduction of ICAM and medical camp.
The topic of today's instruction course is Reaching the Unreached, Human Touch versus Technology. It all started with the medical camps in the 19th and 20th century, which got wide acceptance after World War II. Then after it got specialized, like cataract surgery camps, child health camps and immunization camps, the main drivers were government and non-governmental organizations. ICAMs. ICAMs are temporary community-based initiatives that provide essential, often free or low-cost eye care services to underserved populations, particularly in remote or low-income areas. Why they are important? Camps provide access to eye care in people in remote areas who cannot afford regular eye care. It prevents blindness, like cataracts and other eye diseases. Economic and social impact of camps are they could return to work after the eye problem is relieved, or children after correction of the refractive error can continue education. How they work? Camps are mobile healthcare to villages that lack permanent eye care facilities, screening large number of people. They provide immediate treatment like fitting of the new glasses or some minor eye procedures. Referral and follow-up. The patients are referred to hospital or they are transported to hospital. And after the hospital management, post-operative cares are done in eye camps. Health education and awareness classes are taken. Systemic health screening for hypertension and diabetes, which are the main causes, which are the main problems in eye diseases. Camp process. Patients are registered, visual acuity is tested, then preliminary examination by ophthalmologist is done. Then he requests for investigations like tonometry, lacrimal sac syringing, BP recording, random urine sugar testing, then refraction by an optometrist. Again, the patient come back to ophthalmologist. The ophthalmologist, depending on the problem, do refer the patient for cataract surgery or dispense with some eye drops and tablets. List of equipments to a camp, from Snellen star torchlight up to retinoscope and tonometer. Team for a camp. The team includes ophthalmologist, refractionist, nurses, pathology lab technician, driver, person for spectacle and medicine dispensing, and local volunteers. Depending on the diseases, patients with retinopathy, glaucoma, or children with significant refractive errors are referred to tertiary eye care center. And those patients who require perimetry and FFA are also referred, and patients who need laser treatment are also referred. All referrals need skillful counseling. Helping incurably blind. Referral to government hospital for certification. Low vision devices are prescribed, and informations on training, job opportunities, social, school admission, etc. are done. State of affairs of camps now. Technology integration. Teleophthalmology. Specialists in urban center provide support to rural camps. Electronic health record for better tracking of patients, follow-up care, program evaluation, artificial intelligence for screening diabetic retinopathy, emphasis on sustainability and follow-up, management of chronic conditions like glaucoma and diabetic retinopathy, fully equipped mobile vans for mobile eye clinic, targeted screening program for school health, diabetic retinopathy, geriatric care. Challenges and adaptations. COVID-19 pandemic was one of the challenges to provide social distancing, safety protocols, and PPE. Funding constraints, enhanced safety measures, logistic hurdles like transport of equipment, supplies, persons to remote areas, human resource shortages, technology adaptation, like teleophthalmology, electronic data record, artificial intelligence, globally recognized eye institutions and NGOs. Depending on the volume of work they are done, Arvind, Fred Hollows, Seva Foundation, Lions Club, Shankara, Operation Eyesight Universal. Failures at eye camps like poor surgical outcomes, poor follow-up. For this instruction course, we have 4 reputed ophthalmologists who are well versed in camp techniques, and they have done plenty of camps. First is Era of Human Soldiers in the War Field by Dr. C.V. Andrews, Professor Emeritus of Ophthalmology, Jubilee Mission Medical College, and past president of KSOS. Corporate and outreach camp activities can be do justice to both by Dr. Radharamanan, past president KSOS, Chief Surgeon, Eye Vision Eye Hospital, Chalakudi. And next topic is government setup still at Stone Age days? Dr. Rohan A., consultant ophthalmologist, district ophthalmic surgeon, district hospital, Palakkad. And next is, will technology take over and human touch will become history by Dr. Tanishri P., assistant professor of ophthalmology, Amla Institute of Medical Sciences, Thrissur. Thank you.
Thank you, Dr. Bhagashnama. Now we will do the second topic, that is era of human soldiers in the war field. Human soldiers is ophthalmologists who are working in the field for ICAM. So the journey through the golden age of ophthalmology and ICAMs. So I have done my MS from BJ Medical College, Ahmedabad, Western Regional Institute of Ophthalmology in 1981 to 85. That time we used to go every weekend, Saturday, Sunday, we go to the remote villages of Gujarat around Ahmedabad with a mobile van or ICAM on wheels and all these ancient photos about 40 years before with the so-called eye theaters in a tent and everything. So the campsite as well as operation theaters are in tents and schools. So we go with a vehicle and usually it is in tent or some nearby schools or somewhere like that. That is about 40 years before in Gujarat and Ahmedabad. So in 1985 I joined at Jubilee Thrissur Angamali Little Flower Hospital. So we started the war field of blindness. When every camp, we used to conduct a camp everywhere all over Kerala from Little Flower Hospital, Angamali. We call it as a camp was a battlefield against blindness. So that time Kerala has a lot of blind people suffering from cataract, and that time there's no computer, no smartphones. Only we have the team of doctors who have a commitment and courage. So each OPD felt like a mission field or war field that time. So Padma Shri Dr. Tony Fernandez was a pioneer to start the community healthcare or community eye care in Kerala. So this Little Flower Hospital in Long back, about 40 years before. So not only Dr. Tony Fernandez, along with so many eminent doctors like Dr. Epan, who recently passed out one month back, Dr. Itera, Dr. Ijamani, and Dr. Noel Moniz. Dr. Noel Moniz died about 10 years back. So these are the pioneers to start the ICAMs in Kerala by Little Flower Hospital, Angamali. Unfortunately, all these people become a KSOS president also. Unfortunately, Dr. Noel Moniz became only a scientific committee chairman. That time he died. And the ICAM started from, used to go from Kasaragod to Kanyakumari under the commandership of Dr. Tony Fernandez. And so many captains also. Dr. Noel Moniz was the first captain, then followed by myself. Then Dr. Radhamanan became the captain. So we travel all over Kerala conducting camps. And later, other eye hospitals also started eye camps all over Kerala. So these are the old camp photos done by Tony Sir. So you can see Tony Sir is examining a patient very, very long, about 40, 50 years before. Then these are later photos. And this is a makeshift operation theater in a school, in the various areas or tent, etc. And this is a post-operative examination by Tony Sir after cataract surgery and everything. So these are some of the old eye cams. So this is a Dr. Epen examining a patient in the cam. This is Dr. Itera examining a patient, and this is Tony Sir examining. So this is Dr. Radharamanan, and this is myself about 35 years before, and this is Dr. Radharamanan about 30 years before. And these are the team of doctors working at, doctors and staff working at Little Flower Hospital, Langamali that time. And Dr. Chelsea also sitting here. He was, Dr. Rogan was here. All the teams that time about 1979. And these are our team members relaxing after cam, hectic cam. This is myself, Dr. Radharaman, everybody. So these are the doctors we do work in Little Flower Hospital, Angamali for the last 40 years. We assembled together in 2023 during the All India Ophthalmic Conferences. All these people work, these are all soldiers of Little Flower Hospital who are in the field of eye cams. You can see all these faces in this conference also. Majority was came for the conference also. And you see a flood of patients marching through the OPD. So these we call soldiers or army people. And there's a endless queue. There's a long queue. There's no record keeping, no computer, nothing, no appointment, everything. Only manual record keeping and shouting the names and the queue only. And usually every camp there will be 500 to 1,000 patients will be coming. And you know, the waiting room looked like a railway platform those days. Many of them had cataracts, so at least 500,000 people waiting for a camp examination. So these are some of the camp photos. Usually the camp will be conducted in a makeshift arrangement in with some curtains or some tarpaulin or something like this with a mobile vehicle and everything. So patient will be waiting in the shed and everything, and there's a big queue and everything. So these are some of the old photos of eye camps. I see just like a warfield of blindness, when every camp was a battlefield against blindness. We will be going with a packed instruments in a small vehicle like this, generators, containing autoclaves, surgical trays, because that time we conduct the surgery at the campsite itself, either in the school or nearby church or some places, and that way makeshift operation theater when we make. Everything will be carried in this vehicle for this camp and everything. Later we purchase a bus. And always we stay in schools, panchayat halls or parish hall, etc. Or sometimes we will be resting at under the star also, and there will be rain, potholes, or usually power cut, etc. And there's no Google mark to locate the campsite and everything. So the local tea shop fellows, when you bake for tea, they will say where is the camp and everything. So we make a makeshift operation theaters. This is Ahmedabad. We're making a theater on the campsite with a tent and everything. But Angamali, we usually go to some nearby small hospitals or some schools, etc., making it an operation theater. And usually the tables become the operation tables, and the torches or lamp will be the OT light. And we'll use a portable microscope later, and usually sterilization by boiling sterilizers. And the most important thing is we all have a courage. That's the main thing. And that time we do only intracapsular cataract surgery, and usually we do about 200 to 300 surgery per day. And they will be admitted for 1 week, and somebody will be posted there for 1 week. So we also conducted ICAM in Lakshadweep also, so mainly the Kavaratti Islands. Dr. E.J. Mani and Dr. Radharaman were the pioneers for these camps. And Dr. Hamsakoya later became the Director of Health Service in Lakshadweep. Fortunately, he was my classmate at Kottayam Medical College, so it was easy for us to arrange the camps. So we conducted many camps in Lakshadweep from 1990 to 2018. So these are some camp photos. We are VIPs going there in Lakshadweep. So the government of India will provide us for a helicopter and everything for traveling to different islands and everything. So this is some of the campsite. And this is a makeshift operation theater at the Kavaratti Island. A patient waiting for operation, there is post-operative patient after surgery, etc. So camp was a joy of teamwork. when friendship was the best anesthesia. Doctors, nurses, volunteers, drivers, all part of one mission. So we shared jokes, simple meals sharing, local hospitality, and laughter. So that's our main enjoyment. And success of each camp celebrated like a festival after the workout 2 or 3 days. So these are the enjoying at the Lakshadweep. And this we are enjoying at a beach hotel in Kannur, near the sea, Arabian Sea. After the hectic workout 2 days, we are relaxing. This is myself, and this is Radharamanan, and Dr. Mohan Rajan. I think Rohan is also somewhere here. So these are, and Dr. Chels also, I think, later joined. So all these people are now sitting in front of me also. So it is a surgical evolution. It started with the intracapsular cataract surgery. So later we shifted to extracapsular cataract surgery, and later modified the small incision cataract surgery. And nowadays people are shifting to phacoemulsification, partly business also for training purpose for the fellows and everything. So these are previous operation theater. Now it has become a sophisticated operation theater. So intracapsular we have reached up to phacoemulsification. That is a evolution going on in eye camps. And there's no Google, so we collect experience. So that time there's no CMEs. All the CMEs are just like collect more experience by conducting camps and seeing patients and do maximum surgeries. So that KSOS makes experience. So that we call the CME. There's no internet, no CME like this. Only journals, some correspondence, some observation only. So all the papers we made from camps, etc. So all these papers, camps we converted into award-winning papers, also community ophthalmology. We present most of the All India Ophthalmic Conference and KSOS. It's a community ophthalmology. We present this. That time there's no computer. We use a notebook, typewriter, etc. And usually graphs and with rulers and pencils, we make everything. And we dedicate everything for a workload of wisdom. And finally, we achieved so many presentations in All Indian State Conference, and we make an award also for that. And these camps also, we shift into a training propaganda for Cataplasty or eye donation also. Tony sir started the IBANG Association of Kerala at Angamali in 1970. Wherever we go, we will give classes for the people, public, for the awareness and motivation program for eye donation program also. Because that time we are getting eyes from Colombo, IBANG from Sri Lanka because of the Buddhist people donating. Later, we got eyes from Rajasthan and Gujarat from the Jains, and we started the IBANG Association, and we started motivating the people with the help of social and religious organizations along with eye camps. So we will take classes for them, and we motivate how to donate the eyes. So we will tell them, don't burn or bury your eyes, donate your eyes, that will give light up to 2 people. So let the child smile with your eyes. Donate our eyes. That is our motto. So summary, only human touch, no technology to reach the unreached. We are true soldiers fighting blindness with heart and hands. Technology may have changed, but the compassion remains timeless. Message to the new generation, never let machines to replace humanity. So all the camp now become a sophisticated camp. All the operation theater now become a very sophisticated operation theater also. But the technology has changed, but the human touch should not be lost. So salute and thanks, saluting every unsung soldier of sight. Gratitude to team members, hospitals and patients. Dedicate this journey to all who believed in service. So we have to go without or without ego. So we can go for eye camps. Thank you very much. Hello. Next speaker is Dr. Radharamanan from iVision Chalakudi. He will be talking on the corporate and outreach camp activities. Can we do justice to both? So he's from iVision Chalakudi. He was previously at Angamali with our team. Last 35 years, he is doing eye camps. Forward to Dr. Radharamanan.
Good afternoon. And subject I have to talk is corporate and outreach camps. I think the camp Dr. Andrews was explaining was of a different thing, and now the picture is changed. Now it is for the publicity. That is the purpose for either both for charitable as well as corporate hospitals. Earlier intentions, it was mainly to serve the people, to reach out the remote places. Even surgical camps were conducted, as Andrews mentioned. We conducted a lot of surgical camps. Now you know that other than in proper OT, surgical camps are banned. There was no money collected from any one of these patients on that days. Even Modi conducted camps. What is the change at present? Now, of course, the government hospitals also conduct on the mobile eye clinics. Charitable hospitals conduct camps for poor patients. That is there. But even in charitable hospitals, most of the hospitals do it for publicity, and surgery is not completely free. So that is good. Actually, it's not necessary. And few of the surgeries will be subsidized rate. But in Kerala, now the most of the camps are conducted not by the charitable hospital. It is conducted by either the private or the corporate hospital. I work in a private hospital now, and I am conducting camps. The aim is publicity and convert the patients into the paying side. Where are all we conduct the camps? Through the NGOs, we can do it with residential associations, schools and colleges, offices, anywhere. Now it is reached in a stage that we will conduct it anywhere in Kerala. And this is a camp conducted in High Court of Kerala. So that stage we have gone. Facilities for camp, compared to the earlier days, these are all high-tech camps now. The basic refraction is there, doctor consultation that is there. Then along with that thing, auto fundus camera, then optical shop. Now there are mobile eye units which goes into the peripheral and with all the facilities. The main question comes now is whether these camps are needed in Kerala at present. What will be the answer? Say, if it is for the hospital, yes. If it is for the patients, not much, because there are most of them can afford it. But only in remote areas, like some areas in Wayanad, Idukki and all, definitely requires camps. But sometimes this is not correct. I was remembering one of the occasions where Angamali, the government setup was not coming and screening it, because they were telling that LF is there, so no need. And because of that, they want to complete the statistics. They came to Angamali. They found that lot of bilateral mature cataracts. That was surprising. So the camps are mainly at present for the hospitals. Then another system is CASP. That is Karunya Arogya Suraksha Pathadi. It's a good program both by the central government as well as the Kerala government. But the problem with the private hospitals and all is the rates are very low, and you won't get the money at time. There is a new program called 70 plus, that is Vayo Vandana by the central government of India. And till now it is not implemented in Kerala, because everyone is coming with that cards to most of the hospitals, but it is not implemented in Kerala. This is irrespective of the income of the patient. So even Adani, Ambani is included in the Vayo Vandana. So the question is, who will control the camps? Now it is reached. Previously we were asking for more and more camps. Now the question comes, who will control the camps in Kerala? You know the rules for conducting the camps? You have to apply to the DMO's office. You have to get the permission. There are a lot of procedures. Rohan is there. He is aware of the procedure. And if you give an application, you won't get a reply within the next year also. So they will tell you that if you want to conduct, you conduct it. There won't be any reply from that thing. You yourself will find it out. Then who will restrict it? KSOS or district associations? How can you control it? Which hospital you will control it? So what are the criteria for camps? These are all the things we have to discuss it. At present, we can tell that there is no control for any one of the camps in Kerala. What are the ethical ways? This is at least the minimum thing we can do it now. Doing whole thing is a difficult one. At least do not conduct an eye camp in front of another clinic or hospital. So sometime it is within 100 meters or just in front of a hospital, because and the same paying patient is going there. You can go and conduct it in the periphery. What is the area of one hospital to conduct an eye camp? Can you define it? So this area is for this hospital. You cannot define it, because in the same town, within 100 meters, you can find 4 or 5 hospitals. That is also not possible. So there is no such rules in Kerala. Even outside Kerala, people used to come and conduct camps in Kerala. Who arranges camps? In every hospital. Many times the camp organizers are there in the hospital, and they will arrange the camps in association with some NGOs or some other people. And even the doctors in that particular hospital won't be aware of where the camps and what they are doing it. So sometime when you go there, you will find out that you are just in front of another doctor. So because you don't know where you are going, because the hospital, some other people are arranging. That is another difficulty. And most of these present day hospitals will have a target given to camp organizers. And to reach that target, they will do any sorts of arrangements, and even they can, if the number is given to them that a month this many camps, they will split up the camp, they will do all sorts of things, and these type of things are going into an unhealthy way. So what we can do other than, because this is all for the publicity, we should conduct it in some other way, or should not conduct it in front of another hospital and concentrate camps in remote areas. Total free should not be done. I think it's only for the very deserving people. Otherwise, it is not nice. I think ideally we can concentrate on other publicity methods. There are so many. This is all based only on cataract now. So other than that thing, we can conduct it in other way. Hospitals can get publicity, like a World Sight Day, so many things, glaucoma day and all that thing is there. And other education programs also will help the patients. Whether the hospital associations can do anything on this side? This is a question actually I want to ask. I think we have to initiate a discussion among us to have some norms in conducting the camps. Thank you.
Thank you, Dr. Radharamanan, highlighting the ethical aspect of conducting camp, especially in corporate sector. So next talk will be Dr. Rohan. He is the District Ophthalmic Surgeon, Senior Surgeon at District Hospital, Palakkad. He is conducting camps all over Palakkad, Malappuram, all these areas. So he talked on East Government setup still in Stone Age days. Actually, he is the proud ophthalmic surgeon having a mobile bus for conducting camps. Only district hospital with a air-conditioned bus and everything. So with a DMB course also. And conducting camps every day or every Sunday or something like. And he is my DMB student at Jefffer Hospital also. Over to Dr. Rohan.
Good afternoon. First of all, let me thank Dr. Andrews for his energy pushing me into this one. And I am honored, like this platform is given for at least some government doctors. So today, whenever we talk about government, we talk about all Stone Age days only. So are the government ophthalmic is still in Stone Age days is the discussion today. അത് ഓഫാവും ഇതല്ലേ So, are we in the Stone Age or in the building stage? See, government ophthalmic units is often labeled as outdated, under-equipped, and bureaucratically paralyzed, even though it is the backbone of the community eye care in India. The problem is the lack of awareness, coordination, and strategy planning. As we know, like in government service, the promotion depends upon the service. So whoever may be coming at the top may not be an ophthalmologist. The problem starts from there. So, and even in the meetings, even the senior most ophthalmologists may not be called for. So without an ophthalmologist, how can you make a strategy? So there itself the problem starts. So it is not that the development is not happening because of the poor strategy planning and awareness. So change, and another thing is that we all sit like the change or some instruction will come from Delhi that we should do this. But it will not happen. So change has to happen in yourself. We all know without money nothing will happen. So treasure hunts. Treasure you have to hunt it and take it out. Like the funds doesn't fall from sky. You have to know where to look it for. So in government we will have so many funds which are available when compared to the private. Be aware of NHM fund and NBCB fund, DBCS, CRS fund, RSBB fund, Jilla Panchayat, MLA, so many funds are available, but you have to catch it at the right time. So that is the only thing. Learn to prepare project. That is very important because project preparation is an art. So you keep doing, you will slowly improve. And another thing is that in the government, they will ask you that 2 o'clock there is a meeting, you submit a project, you will there is a fund available. So what I used to do is that I keep the project ready always, and the moment they ask, I will give the project. That's why I got so many other things. So don't stop writing the project and keep a project always ready. And like each time you prepare the project, you will slowly improve it. Money isn't missing, it's just not unclaimed. Geography is also very important. The population size and density you should know. Then economically and socially backward group, including the tribal community. This is a very important thing. You should know the strategy, how much of the people are backward and tribal. And this, in each project, I used to write that is one of the backward district of Kerala with the highest tribal population. See, this is not that like you will definitely get some fund in that. If you mention that one, and you should not bluff it also. So you should have a realistic statistics, how much is the tribal population. And you should always address on the common ocular disease. Like if you are trained in some retina or something like that, you try to implement that, it will not work. So first you address to the local disease, and then slowly, stage by stage only, you should go. This helps privatize infrastructure and outreach activities, definitely. Then if you don't know your people, you are just treating eyes, not the blindness. Our main thing is that you have to treat the blindness. So this is just like a picture. You have to show it in all projects with the density of the population and the urban population, some rural, very rural population and tribal population. You just put it like this. Whether they understood or not, you put a picture like this. Then implementation system, policy, paperwork, and patience. The real operation theatre. Say the real operation theatre is the pen work. And you have to be patient enough. See, nowadays nobody is patient. You write it, you expect the next day to come get it. You will never get it. You patiently wait and keep doing, you will get it. That's the main operation theatre, not that doing the surgery at least in government. Even in private also like that. They will monitor you, how much the income they are getting in. Understand government policies for equipment. This is very important. You go to the office, they will tell you like so many things. If you put it like this, there will be audit objection, there will be this thing, that thing. If you study properly and go and tell boss, you do it like this, there will not be any problem, they have to do it. Another thing is that our superintendent will be like a senior most person who is going to retire maybe after 6 months or 2 months. She will not sign in any paper. So we had to understand, make or him understand that this will not create any problem for her pension. So these things you have to learn how to purchase the instrument. That is very important thing. Then smart growth, categorize your infrastructure based on the local. Again, I am telling you have to categorize on the local needs. Strengthen the existing services. Our problem is that if you come out of some good institute, tell this is all wrong, we going on, and you try to demolish it, that no, it will not happen. So you try to build up what is existing there. I did the same thing because in that mobile unit, what was happening was at that time Aheli and all was not there. What is happening? I have given a van where one doctor and optometrist will go, see the patient and come back and give a date and waiting for the thing. Nobody turns up. Then I realized that the Aravind people are taking the patient on the same day. So I told I need a van or a bus which is an 18-seater or a 16-seater. I told DMO, then DMO understood that he has given this thing. Then with this van we are going like that, then they will ask, are you coming from Aravind? No. So without Aravind, who is there? 3 months, 4 months I took for me to get one patient into my 60-seater bus. From there we started, slowly we started. That is the thing we had to do it. Then we have to categorize like primary, secondary, tertiary, not the the ophthalmic tertiary, secondary, inside your department. The primary and secondary should be distributed with the optometrist and some other health workers and ASHA workers. That monitoring is not about buying, modernization is not about buying machine, it is about creating meaningful service. What I was telling is this, meaningful service can be any field, like school screening, taking classes for the ASHA workers to get the blind people or blind register properly done, get the data of the, diabetic data, all these are meaningful, this thing. So mentor role is also very important, but fortunately or unfortunately, I didn't have any vendor as such in the government. But my vendor was Andrew sir and Radharamanan sir. Whichever any problem I call Radharamanan sir. So I'll get the full correct description what to do it. And not only for this one, for anything, starting OT or starting anything. So before you leave, learn from those who are landed. Seek guidance from senior colleagues when planning for a new project. Invite them for the prior revision. If you are very close to them, you can invite them. And they will tell you what all. See, if you are close to that fellow, they will definitely tell. See, nowadays, nobody wants to tell you the truth. They will tell you that I am doing like this and they will be doing something other things. That we all know that. So, and another thing is that we try to build a wall between that bureaucrat and the administrative thing. Never build a wall against them. They are also human beings. They are also have their own feelings. So always put a bridge which is very strong. And not that I am telling you go and talk with them and muskify them. Nothing like that. You do your duty and put a bridge so that you can collaborate with the local bodies like Panchayat, municipalities, DBCS, voluntary organization, learn how to get the funds. And then slowly you have to learn how to get funds. This Jilla Panchayat and all is worth like crores. We can't even imagine the amount of money they are getting. So if you just asking for few funds for a hospital is peanuts for them. It's like 3 MBs fund is for Jilla Panchayat. So that much of fund they have, and you should go to their room also, no? Fully wooden paneling, everything, that shows the sick. So this is the, then this is the things when our Honorable Health Minister inaugurated the fluorescent angiogram. This is our telemedicine bus which has been inaugurated by then Minister. We can see the MLA and MP as well as this is the Panchayat President who is inaugurating our OCT, NCT and all. And recently we have started, in fact, the vitreoretinal surgery with the help of true course has been given by our Jilla Panchayat, and we had started our vitreoretinal unit as well. So everything is possible if you go in a very systematic way. So building, the team building is the very important thing. And like you have to, firstly, you have to build a very strong team. And as you know, like when government own team will not exist, like they will be shifted out. So if you build a very positive team in the beginning itself, then that legacy will follow. And we have a telemedicine which goes all around. And this is what I was telling, incorporating the community. No. We have done a cataract screening with the help of NSS volunteers as well as Ashra Michelle Popping. This is the doorstep cataract screening. Very few screening like this is done. This primarily done by these people, and then second time the optometrist will see, third time only the ophthalmologist will see, and we have done around 400 to 500 cataract surgeries from this to make it cataract. It is not cataract free, but at least we could do this one. And this is another utilization of the resource, training the optometrist to take digital photographs, digital photograph, fundus photographs, and all these things. Then this is another thing, we are sharing the responsibility to the local ophthalmologists as well as optometrists for seeing in the slit lamp, and also that fundus camera. And this service we are doing for the last 12 years is very amazing result we are getting, in the sense without compromising our time, we can reach the unreached through telemedicine or teleophthalmology. And we do give treatment for them also, all the medical retinal treatment. And to some extent, with our limitation, we are doing retinal service also. And always keep learning, keep learning. Once you stop, then you start rusting it. And technically, this is so many things I have to talk about this one. Before you plug in, you have to tune in. You have to know even the electricity connections as well. The main fund we got is NBCB, District Panchayats, RSPY, hospital development. These are all the instruments we have installed through all these funds. And we have got the best in a take home from Stone Age. It is changing. Government ophthalmology is not outdated, it's evolving. We don't need to wait for the change. Each of us can spark that modernization of our system step by step. So the spark has to come from you. And you can see that, see the difference. This picture itself is self-explanatory. The human touch is better or the machine touch is better. This human touch, definitely you can feel it in your body, With the human touch, you will have the vibration going to you, empathy, sympathy, everything will be there. But the machine never can give this type of thing. Thank you all.
Thank you, Dr. Rogan, sharing the government setup in Kerala, especially Palakkad. And he has about more than 10 crores of rupees he got from government of Kerala for instrument. And recently, vitrectomy also, and keratoplasty, eye bank also. I used to go there and do keratoplasty also, squint keratoplasty, etc. So far we are talking about the human touch and everything. So we are soldiers working in the field. Now we come to the AI scenario. Dr. Tanushree from Amala Insurance Science, she will talk on, will technology take over and human touch will become a history? So last 4 speakers, we are talking about human touch. Now she will talk about the implementation of AI technology in iCam and everything. So you can leisurely sit at your office in the air condition and somebody will go to the field and do the cam and everything. I think so. Anyway, over to Dr. Tanushree.
Thank you, sir. Thank you for giving me this opportunity, and I thank the KSOS Scientific Committee also for giving me. I'm extremely honored to share the. Yes, sir. Thank you. Let's, without further any ado, let's move on to the topic. First of all, let's just brush up what are the key areas where the tech or the AI has been in clinical use. I'm sure everybody would be knowing at the moment. First of all, for the accurate diagnostic imaging. Now we have for clinical documentation, like instead of typing in the EMR, we have real-time note transcription. Even virtual health assistant like AI chatbots have come up, and personalized treatment. Now coming to the ophthalmology part, like apart from that, there are extra more and detail sort of technology has been very much well incorporated in the field of ophthalmology. First of all, in the accurate detection of the eye diseases, enhanced screening modalities, as well as accelerated drug delivery, and in the field of research. So what are the role, or per se, what has AI come up in anterior segment diseases? The first one in the, first of all, the corneal ectasia detection, especially the Pentacam random forest index, offers breakthrough accuracy. And also the Smith et al. And the Shen et al. Models have shown around 97% accuracy in detection of the form frustricate trichonis. Now, what about an AI in posterior segment diseases? It has just revolutionized the diabetic screening, and the AI-powered screening using the fundus imaging and the very well, teleophthalmology has been very well used right now. And the first FDA approved AI system for clinical use is, I'm sure all of you know, it's the IDXTR. But now, see the list. This is actually accessible to everybody. You all just have to type in the FDA, the AI-enabled medical device in the internet or in the Google, and you will find the devices. And right now, from the 2018, which was one medical AI-enabled medical device, which has come up 2018, now there are around 10. But it's all based on fundus camera, nothing as such for anterior segment, FDA approved. Anyway, it all actually, apart from DR, now it's able to detect ARMD, RD, and even ROP screening. Now, what about in glaucoma care? In 360-degree, the AI has come up in glaucoma care, 360-degree actually. Let it be the patient education or glaucoma screening, or let it be the predictive analysis and even outcome of the patient, has all, the AI has been incorporated in all of this. And what about the cataract surgery? Now we have AI-based IOL power formulas, and also the breakthrough news which has come up, the robotic AI-assisted cataract surgery has also in the, it has just been performed recently, and it's been in the news. So coming to the topic proper, the rapid AI adoption has been come up in the clinical practice. So while we compare with the global adoption, which is a 48%, this is according to the Clinical of the Future survey 2025, the Indian adoption isn't so far behind. We are around 41%, which is a great turnout. Actually, from previous year it was just 12%, now it's 41%. And almost all of the investment focus, around 75% of the investment focus has been right now in healthcare AI related ones. So the India surging AI adoption as a global leader in the growth is very fascinating. So it's actually 3 times growth right from the previous 12%. And China, of course, is the leading, and this is just a snapshot where we are at the AI and the tech use. It is interesting to see that we are a little tad bit above US. That's because we use a lot more chat GPT. That's what the survey is saying. But anyway, China is leading. So primary benefits, what we can say is extremely time-saving. With the help of AI, we have time-saving benefits, professional empowerment, and efficient workflows. But the thing about the support gap, we have a big deficiency in the support gap in terms of lack of digital tool support as well as training deficiency. So what's needed actually is better guidance and institutional support so that we can have an ease in the workforce training. So said about everything positive about AI, there are disadvantages, of course. First one is the bias. When we give unbalanced training, like for example, we are not giving a value of a type of ethnic or a subpopulation, we can lead on to a diagnostic error. Next one, of course, there are risks for data privacy and the ethical concerns. For example, there is a lack of standardization between the countries and the black box theory exists. Any idea what this black box theory? So basically, we are actually putting some inputs into a software. That software detects what's been taught and gives an output. So how it actually derived that sort of output is still hidden. It's not transparent, that process. That's called as the black box theory. But soon, I'm sure in the future, it will turn out to a white box. But still currently, right now, it's in a black box. It's still hidden. It's not transparent how it has come up into that output situation. And of course, as Sir said, the lack of human qualities like empathy, the multifaceted thinking and nuanced judgment, all these are lacking. So these are the main disadvantages. So after discussing all this, the technology promises perfect diagnostic accuracy with optimized therapeutic interventions, a streamlined workflows, as well as great drug development. But the question or the critical question that we have to think about is that how can we harness the AI's capability to enhance the human touch, not to diminish, but to enhance it? How do we do that? How do we attain that? And that is only by a great interdisciplinary collaboration and great learning. So, how do you get that learning? That is by equipping the present and the future clinicians. So, when there was a survey for the medical students on the AI outlook, and more than 80% felt that they have that desire of AI teaching. They need more AI-based teaching, and they feel that it will boost their careers itself. Hence, what the main point we want to say, put across in this IC, is that the medical schools at present should incorporate AI in their medical education curriculum, and keeping in mind the ethical implications being the paramount focus. So few points that we can say is that we can develop modules and courses that cover the basic AI foundation courses and how the AI diagnostic works from the time of MBBS itself, and give the students a hands-on training opportunities, as well as encourage the AI projects and case studies. And very interesting news that has come up. I'm sure all of you have read that. The Education Ministry has offered lots of AI courses, and that too free, in the field of sports, education, finance, and science. So why not in MBBS curriculum, or why not in medicine? That's the billion-dollar question. And we are so happy to see the SSTC on AI here at Drishti. That is a plus thing. And so I'm sure it'll be coming up. Hence, so why human touch still matter? So I'll just briefly say, you are in a very big, you have a big problem in the bank, and you're facing a lot of difficulties. So you are keeping on texting or chatting with the virtual chatbot, but what you want is a basic human touch where you want to get it solved. So similarly, patients may trust AI in initial screening or the diagnostic, but when in a vulnerable situation, you need that human touch or the element. So it is irreplaceable. Human touch is irreplaceable because of our clinical judgment, the surgical expertise, empathy, and ethical oversight. So to conclude, our world may be built on data, but the quality, the emotional or the empathy quality has still been behind for the AI, but I'm sure in the future it might develop. So to conclude, a food for thought for all. Artificial intelligence will not be able to replace ophthalmologists in the future, but the ones who use AI are bound to replace those who don't. Thank you.
Thank you. Discuss a minute. Thank you, Dr. Tanushree, for highlighting the importance of AI technology in ophthalmology or ICAM and everything. I thought she will be against human touch. She said AI technology only to enhance the human touch in all the activities, camp or whatever it is. I think future will be for AI, whatever it is, medical care, eye care, or ICAM, anything. But you have to incorporate, there's a balance between human touch and the technology and AI, etc. Anyway, she has highlighted with the presentation also high-tech or AI technology. So Avesa, all technology, she was using a new technology, slides, quality and everything. Okay, thank you, Dr. Tanushree, because she belongs to the new generation. We are the outgoing generation. Okay, any discussion regarding any camp or anything? Because we have people for conducting camps for the last 30, 40 years, facing all the hardship and everything. Especially you can ask some questions to Rohan also, how to conduct camps or how to achieve some money from government of Kerala, etc.
Regarding this AI, actually Google actually already have one program where you can make your own artificial intelligence thing. You just have to feed it into that one and you will get the inference in the sense. So already it is there. So as rightly she was mentioning, it should be taught from MBBS time onwards. Probably we may, like, see, we all know, like, medicine is becoming very difficult. So we may get a twist and we can go to some artificial intelligence engineering technology, because as I was discussing with my brother's son, he is doing artificial intelligence in Edinburgh. So I was discussing with him. So he was still telling the problem is the data. See, we have to have huge data to come out with a real-time result. So once the data is through, anything can be done. That's what he is telling. So they are now they are collecting data with a walls, like from the chromosome you can find out like what you call when a small cell you'll be able to find out which cancer he is going to get, whether the patient if it's a diabetic patient is there, whether he'll develop diabetic nephropathy or retinopathy. So these types of things can be done, but only thing data is missing now. So we are the people, we are giving the data and we will be dying also. So by itself we'll learn artificial intelligence and we'll be more intelligent.
Thank you, Rohan, for highlighting, because this complete title, all these data, heading, everything artificially made by Dr. Rohan, because if you give a IC with a ICAM, role of ICAM in community-based education or something like in Kerala, it will not be accepted in the scientific committee. So Rohan used the artificial intelligence or high technology and he edited and everything. So how to reaching the unreached human touch vs technology. So nobody will know what it is, whether it is a medical camp or what it is. So it is a one way to influence the scientific committee chairman and all these people also. So the IC will be accepted. And all these heading also, all the titles, everything artificially made or something like that, because Rohan is also a little high tech with the artificial intelligence and everything. So those who are audience sitting here, in future also you can modify your, when you're submitting a IC, you can modify the heading and everything, because you go through all the flyers are artificially made or something. There's no direct flyer or something like that. All the topics are indirectly they are hinting. So then only you get the audience, you get to get some audience listeners also, and it will be accepted by the scientific committee also. So that way it is. Anyway, any more questions? Okay, if it is not there, so I thank you very, the speakers, all the scientific committee chairman, all the audience, as well as the audiovisual people and the floor manager also, especially keeping everything. She was telephoning me and everything, interfering, come sir, come, etc. And we got an extra 5 minutes also. Before that, Sai Umar has given an extra 5 minutes also. So I am able to keep in time also. So thank you very much once more. I think we have a group photo also. Thank you.